Hypernatremia, dry, sticky membranes. Sure, because it's very dry. I challenge you to go eat a spoonful of salt and tell me what happens if your membranes don't get dry and sticky. Your skin is flushed. You have a cough, and again, it's from the dryness. Ever had a dry, tickly cough? Something sticking in your throat, and you're just coughing. It's dry, hacky, sticky. Your tongue is dry. You have tremendous, tremendous thirst. And what are some of your nursing interventions? Well, it's basic. If you don't have enough, you give it. If you got too much, take it away. How many of you guys have cooked? Okay, and you went to making soup or making a dish or something, and you go take the salt shaker and you go to shake some salt in, and the top falls off and the whole salt shaker falls in. How many of you have done that? We've all done that, right? Well, we got two choices here. We've got some choice. We can scoop the salt out. Yeah, right. It's already in there. You can't get the salt out. It's already in. Okay? So we can take it out, which is going to be difficult, or we can dilute it. So if we add a lot of water, we can dilute it out. Okay, so now instead of making food for 2, you have now made food for 30. But it's okay. You didn't waste the food, and you didn't waste this 49-cent bag of salt. Okay, so it's very simple. If you don't have enough, you give. If you got too much, you take it out, or you dilute it. Makes sense, right? Okay. Now, was that easy? Okay. All right. Our next electrolyte is potassium. Now, the same thing that I talked to you about with potassium, with sodium applies to potassium. Potassium transmits electrical impulses and muscle contractions as well. Right. Now, we need potassium to maintain an acid-base balance. If you look at your periodic table of elements in your chemistry, I know that was a long time ago, but go home and pull out your chemistry book and look at the periodic table of elements. You will find that potassium and hydrogen are on the same level and the same side. Okay? Hydrogen is number 1 and potassium is right down the same level. Okay? Now, what does that tell you? It tells you, therefore, that potassium and hydrogen have the same qualities. That's basically what and again, I'm doing nutshell simplistic, okay? Have the same qualities. All right. If you have potassium is very important with acid-base balance. Very, very important. If you've got a situation of acidosis, okay? So with acidosis, you know that with acidosis what happens? You've got a lot of hydrogen ions, right? With acidosis. So the body doesn't like to have a lot of hydrogen ions sitting in the blood. So what it does then is takes the hydrogen ion and it dumps it into the cell. Okay, it moves it, wants to get rid of it. Doesn't know how to get rid of it. The best way to get rid of it is dump it into the cell. Well, when it goes into the cell, it gets kind of crowded. There's not enough room for the potassium to stay in there, so the potassium comes out. Okay, but that's one way that the body works to compensate for acidosis. It'll take the hydrogen, put it into the cell, but the potassium comes out. So in a situation of acidosis, you will find a situation also of hyperkalemia. Write that down. Because it's very simple, and there is an NCLEX question about that. With acidosis, you have hyperkalemia, high. Okay? With alkalosis, you have hypokalemia, other way around. So that's how your potassium works to maintain acid-base balance. All right, if you don't have enough potassium, okay, you've got a situation of hyponatremia now. Okay, it's less than 3.5. Now remember that you remember how your heart works, right? You got the SA node, right? The SA node fires, sends an impulse down to the AV node. The AV node fires, sends an impulse to a bundle of his Purkinje fibers, right? And so you know that's how the heart works. Well, guess what happens? Remember potassium, we need this for electrical conduction. Okay, if you don't have enough potassium, SA node slows down its firing. Now, what's the intrinsic rate of the SA node? Well, the intrinsic rate of the SA node is between 60 to 100, right? What's the intrinsic rate of the AV node? Now, I hope I'm not speaking Greek to all of you, and I hope you all know what the SA node is and the AV node and Purkinje fibers and stuff like that are, right? If you don't, well, you might want to go home and look at your anatomy books. So, your SA node if you don't have enough potassium, your SA node doesn't fire as much. But again, back, intrinsic rate of SA node is 60 to 100. Your intrinsic rate of your AV node is what? 40 to 60. Your intrinsic rate of your Purkinje fibers, your ventricles are in the 20s, 20 to 30, 20 to 40. Okay? So, here's what happens if you don't have enough potassium. Your SA node's intrinsic rate is 60 to 100. If you don't have enough potassium, maybe it won't fire it doesn't fire as much. Okay, so if it doesn't fire as much and it drops below the intrinsic rate of 60, then the AV node can take over. Remember, your SA node is the pacemaker of the heart. As long as that is functioning and firing, the AV node doesn't get a chance to fire because it doesn't need to fire. But if your SA node falls down on the JOB, then your AV node will take over. No question. And if your AV node falls down on the JOB, then your Purkinje fibers, your ventricles will take over. No question. The problem is the ventricle firing rate is not compatible with life. But, so you follow. If your SA node doesn't fire because it doesn't have enough potassium to cause this electrical firing, then your AV node can take over. That's why with hypokalemia you find ectopic beats in the heart. Does that make sense? If you understand this, you can rationalize it out. You always need to understand the physiology behind everything. So, what are some of the causes of hypokalemia? Remember, we lose potassium how? Every time we urinate, right? So diuretics, especially your loop diuretics like Lasix, your hydrochlorothiazides, okay? Those are diuretics, your loop diuretics, and you lose potassium there. Some drugs can actually cause you to drop your potassium levels. Diarrhea, you lose potassium there. Severe vomiting. Well, with severe vomiting, you don't lose potassium per se, but you lose hydrogen ions. And remember, if you lose hydrogen ions, you become alkalotic, yes? And remember I said with alkalosis, you become hypokalemic. See how everything fits one into the other? NG suctioning, for the same reason, you're losing hydrogen ions. So if you lose hydrogen ions, you're hypokalemic. Hyperinsulinemia. All right, what's this all about then? How can insulin cause me to have hypokalemia? Well, insulin does a wonderful thing. Insulin's a carrier molecule, isn't it? It's a protein carrier molecule. And what's the primary job of insulin? Well, the primary job of insulin is to take that glucose from your blood and dump it into the cell where it belongs, because you want to feed the cell. However, what we didn't tell you, we neglected to tell you this as professors, but I'm telling you now, so I'm trying to make up for it, is that insulin has two arms, basically, okay? And it doesn't function unless both arms are filled. One arm has a little bucket in which glucose molecules sit. The other arm has a little bucket in which a potassium molecule sits. Okay, so unless both arms are filled, guess what? It won't work. So when the insulin molecule, the carrier molecule, takes glucose into the cell, it also takes a potassium molecule into the cell. So if you give too much insulin, you have a hypokalemic situation. Okay? You with me? Insulin takes glucose into the cell. It cannot function unless it also has a potassium molecule attached to it. So when it takes the glucose into the cell, it also takes a potassium molecule into the cell. If it takes the potassium molecule from the blood into the cell, what do you have? Hypokalemia. Yes? Okay. Now, hyperkalemia, the other side of the coin. The other side of the coin is when the potassium level is more than 5. And what are some of the causes? Okay, let's go real simplistic now, anatomy and physiology, real simplistic. Remember we said that potassium lives inside the cell, protected by the cell membrane. Remember we said that? Well, gee, what would happen if I broke that cell membrane? The potassium would dump out, wouldn't it? So if I said to you that with any crushing injury or any burn injury where the cell membrane is disrupted, you're going to have hyperkalemia, would that make sense? You bet. But now you understand why. Because we've just broken the cell membrane and we've just dumped the potassium right into the blood. Okay? Any burns, any crushing injuries, hyperkalemia. Okay? How do we treat hyperkalemia? Well, we can give K-exalate, that exchange rosin. You know what that is, right? It's actually a cation exchange rosin. Or we can give insulin. Remember what insulin does? Takes potassium into the cell. Sure. Give them a little glucose, give them a little insulin. Why not? That's an NCLEX question. Thought you might like those things. Okay. Any situation of acidosis will cause hyperkalemia. All right. So now if I said to you, remember, if we don't have enough potassium, the person's going to be, we don't have muscle firing, we have muscle weakness, right? We don't have the nerve conduction either. So if I told you that with hypokalemia, this is what happens. Little muscle weakness here, okay, little fatigue, abdominal distension because nothing is firing. Ileus, what is ileus? That's when your intestine just slows down. Okay, remember, nothing's firing here. Okay? All this is from nothing firing, abdominal distension, because the peristalsis is dropped. Okay, so your stomach is all swollen up. Cardiac arrhythmias, I explained that already. Yeah? Okay, the T wave is flat because, again, nothing's firing. You might see a U wave. Okay, so here's a little acronym for hypokalemia. If you write suction down the side, S-U-C-T-I-O-N, I'm going to go ahead and give it to you. S stands for skeletal muscle weakness. U stands for a U wave. So instead of your T wave, remember you have your P, QRS, T, and your T is positively deflected. Instead of the T, you have a U wave, which is negatively deflected. Okay, so S, skeletal muscle weakness, U is a U wave, C is constipation or ileus, T is toxicity of DIG. You will find DIG toxicity occurring more frequently with hypokalemia. Okay? I stands for an irregular or weak pulse. O stands for orthostasis. Yes, you will be dizzy. Remember, where sodium goes, water follows, and well, this has nothing to do with sodium. What am I talking about? Hypokalemia, orthostasis can occur. And N stands for numbness or paresthesia. So with hypokalemia, this is what you're going to see. You don't have enough firing of electrical impulses and muscle contractions, so you will see that orthostasis. Okay, you will see the numbness because, again, you don't have enough firing. All right? So your nursing interventions. Well, remember, if you don't have enough, you give. So here's Mr. Chiquita Banana right here. Okay, you're going to replace. You can give Kalor or food, Kalor with food or juice. Okay, and you want to give foods that are high in potassium. Now, again, years ago when I first was taking the NCLEX, I looked for bananas and oranges for potassium. Well, guess what? Now it's dried apricots and raisins and cranberries and cran apples and who knows what the heck else you have. Okay, so you need to know what dried apricots, dried fruits are pretty high in potassium. Okay, so you want to give those. You can give IV potassium, and usually it's 10 milliequivalents per hour. You have to dilute it. You've got to mix it in a solution. You never, never, never give potassium IV push. That is lethal. And that is what we do to those people up in Albany when we're putting them to death. Okay, we give lethal injections, and lethal injections of plain old potassium, guys. That's all it is. Yep. Okay, never give that. Again, push. You have to monitor I's and O's. And you want to give foods that are high in potassium. Now, what happens if you have hyperkalemia? Well, you dilute it, don't you? Okay? But with hyperkalemia, you can find muscle weakness, primarily of the lower extremities, irritability. Too much firing can cause you to be very irritable. Just too much firing, okay? Hyperstimulation, arrhythmias, and this is where you find the tachyarrhythmias. Okay, cardiac arrest can occur. Abdominal cramping, hypotension. Again, remember I said to you, hyperkalemia accompanies acidosis, metabolic acidosis. Now, hypokalemia can also occur with blood transfusion, and why is that? Well, red blood cells have a longevity, right? They have a lifespan. What happens with red blood cells when they die is they lyse. And when they lyse, they release the potassium that's inside the cell. That's why when you look at a packed red blood cell unit, you have to figure out where the expiration date. There is an expiration date because after a certain point in time, all the red blood cells have been lysed. They're no good anymore. Okay? But when you give a packed red cell, a bag, 250 cc's, when you give a blood transfusion, you are giving good red blood cells that are whole and alive, but you're also giving some that have died. And what happens when they die or lyse? They dump the potassium that's been inside out. So a person who's getting blood transfusions will become hyperkalemic, and you need to monitor that, which is why what we do a lot of times is in between transfusions, we give them Lasix. And we give them Lasix. So, for example, if she's getting 2 red blood cells, 2 packs, we'll give 1 pack, give Lasix, and then give the other pack. Okay? And we do that for 2 reasons. Number 1, we don't want to stress the heart by giving too much fluid. That's number 1. And number 2, because of the hyperkalemia situation, which is actually the more important situation. Okay? Beta blockers and potassium-sparing diuretics can also cause hyperkalemia. Beta blockers actually have a wonderful way of helping you to retain potassium. Chemotherapy will also cause hyperkalemia. Again, same reason. What are we doing with chemotherapy? Breaking the cells, right? We're destroying cells. And remember what happens when we destroy cells. Any kind of blunt trauma, any kind of burns will cause that. Your nursing interventions, you got too much, you either take it out or you dilute it. Yes? You can't, it's very hard for you to take out hypokalemia. You can do it with diuretics or with that exchange rosin, or you just give a lot of fluids. You can increase the fluids, dilute it. Okay? Obviously, you also want to restrict potassium intake, and you can give insulin. We talked about that. And we know why now, right? Everybody knows why. Light bulbs going off. We can give bicarb, because what happens with bicarb is that the sodium, it's sodium bicarb, Na is sodium, right? What happens if you give bicarb is the sodium exchanges with the potassium and it becomes potassium bicarbonate. The problem with doing this is that now all of a sudden you may have reduced the potassium level, but now you've got a hypernatremic situation. We do lots of things in medicine. We fix one but cause another. So, and you all know that we do that a lot. We can also give IV calcium. Okay, if the potassium is higher than 6.5, and of course if there's none of that works, we can also do dialysis. Okay, calcium. Normal serum level is 8.5 to 10, and we need calcium, as we know, for bone and tooth formation. We also must have calcium for blood coagulation. If we do not have calcium, you will die. Bottom line, you will die. Okay, calcium is necessary for blood coagulation. If you don't have calcium, your blood won't clot. Another thing that calcium is very necessary for is muscle contraction. Okay? If you don't have calcium, you will die because your muscles will not contract. Your nerve impulses will not occur. You will die. So, if you don't have enough calcium and you don't, then it's hypo. If you have too much calcium, it's hyper. Now, I talked to you about the sodium-potassium pump. Yes? Now I'm going to talk to you about calcium and how calcium helps your heart to work. Okay? In your heart, you've got fibers known as the actin-myosin fibers. Going back to anatomy and physiology. Remember the actin-myosin fibers? Remember how they live? They live like this, one on top of the other. Okay, and it's the sliding filament theory. Remember that? They slide one on top of the other, and that's what causes the cardiac. Every time this happens, that's when your heart contracts. So this is the sliding filament theory. However, in order for the sliding filament theory, in order for the actin and the myosin to slide on top of each other and for the heart to contract, you must, absolutely must, no question, have a molecule of calcium that floats through and that stimulates the contraction. If you do not have that molecule of calcium floating through, you don't get the neural impulse, you don't get the heart contraction, you die. Very simple. See? Told you die. Okay, so some of the causes of hypocalcemia. Severe burns and infections because it gets eaten up. Hypoparathyroidism. When we get to the endocrine system, we'll talk about this a little bit more. Hypomagnesemia, too much phosphorus. So if you put too much phosphorus-containing antacids in you, you're going to have hypocalcemia. If you don't eat enough calcium, you're certainly going to have it. Now, what does this mean? Does this mean that we all have to run out now for lunch and have a milkshake? No, not necessary, because some of us are lactose intolerant. I mean, you've got a couple of billion people running around in China, and we're all lactose intolerant. Did you know that? Yeah, we're all lactose intolerant. But we have less osteoporosis in China than we have here, and we don't drink milk. But we do eat soy, and that's very high in calcium. And we do eat lots of green leafy vegetables, and that's very high in calcium as well. So inadequate intake can certainly cause it, and respiratory alkalosis as well can cause hypocalcemia. Kidney failure, why? Because the kidney, the glomerulus has a nice membrane, and it generally does not permit calcium to go through very readily. But what happens with renal failure is that glomerulus, the pores in the glomerulus get large, and so calcium just flows right through, and you lose it. Okay? Normally, you don't lose a lot of calcium through your urine because the filter is intact. Okay? The membrane's intact, the glomerulus. However, with renal failure, you end up getting holes in your glomerulus, in your membrane, and that permits the larger molecules of calcium to go through. And the funny thing is, because it's selective, while it permits the larger molecules of calcium to go through, it does not permit the smaller molecules of potassium to go through, so you actually retain. It's all selective filtration. You have to remember this. Okay, everything in your body is selective filtration. So it will permit this to go through, but not that to go through. So just because I say to you that, it permits the larger molecules of calcium, doesn't necessarily mean that the potassium can go through. You see, he has to have a password, and nobody told the potassium the password, so it just didn't work. Okay. Signs and symptoms of hypocalcemia. Well, you all know this, Chvostek's sign. Now, what you've got to know about Chvostek's sign is you have to be able to explain and describe it. Chvostek's sign is what? Tapping that facial muscle, and then you see an ipsilateral contraction, right, of the muscles on that side. Trousseau's sign is what? When you put a blood pressure cuff on and the hand flaps on you. So there's twitching. So that's Trousseau's sign. But you need to be able to explain that and describe it, because they don't tell you, would you see Trousseau's sign or Chvostek's? No. They actually describe it, and you got to pick the right description. Okay? Tetany you will see with hypocalcemia and muscle twitching. Some later signs can include arrhythmias, because remember, if you don't have the calcium, you don't have the actin myosin sliding filament theory, you don't have the firing of the nerve impulses in the heart. So what happens again, the SA node isn't firing, so the AV node takes over, and you have ectopic beats. Okay? So your nursing interventions, if you don't have enough, you give it. If you got too much, you take it away. Calcium supplements need to be given 1 to 1.5 hours after meals. That's an NCLEX question. They want to know if you know when to give it. Okay, now, if you're giving sucralfate, sucralfate and Mylanta, which one do you give first? Sucralfate and Mylanta. You have to give both of them. Now, what does sucralfate do? Okay. I know we taught you that sucralfate coats the stomach. That's a lie. Sucralfate does not coat the stomach. Sucralfate or carafate coats the area of ulceration. Okay? and it helps that area of ulceration to heal. It does not attach. Carafate does not attach to the intact membrane of the gastric cavity. It only attaches to the area that actually has an ulcer or it actually has a breakdown. So you always give the carafate or the sucralfate first so that it can attach to that area. If you give Mylanta first, Mylanta is non-discriminate. It coats everything. So you give Mylanta and then you give carafate, well, that's no point, is there? Because the carafate cannot get to that ulceration. See? Carafate first, then Mylanta. With hypercalcemia, well, any bone malignancies or fractures or prolonged immobilization, and you know all those things, hypoparathyroidism can occur. Signs and symptoms of hypercalcemia include lethargy, weakness, personality changes, abdominal pain, and constipation. Yes, too much calcium can constipate you. So your nursing interventions, take it away or dilute it out. You can give calcitonin. Calcitonin is that hormone that's produced by your thyroid that actually encourages, that actually takes the calcium from your blood and puts it into the bone. So if you've got too much calcium, hypercalcemia that sits in your blood, you take the calcium and put it in the bone. So that's calcitonin. You can give sodium chloride because, again, the sodium and the calcium will change places, and you'll end up with calcium chloride with free sodium floating around. But what do we do with this? We then send him into hypernatremia. See, we fix one, give him another. That's all. We like to do that. We can give diuretics or PO fluids, and what you got to do is remember two things. Acidify the urine, because with too much calcium you can end up with stones, right? And you want to monitor for digitoxicity, because too much calcium can cause digitoxicity as well. Understanding of the discharge instructions when she says. So what are you trying to find out here? You're trying to find out that she knows what she's talking about, right? So you're looking for a positive statement, not a negative statement, correct? Okay. So she demonstrates understanding of the discharge instructions when she says, I can use safety razors, or number 2, I will not allow my child to swim, or number 3, I will encourage my child to do range of motion when joint pain occurs, or number 4, I will teach my child safe sex practices. Okay, first of all, what's a safety razor? Let's go back to number 1. No, an electric razor will be listed as they will stipulate electric razor. A safety razor is a big razor, a chic razor. It's still got a blade on it. That's a safety razor. Okay, so a safety because you have a cover to it so you don't cut yourself, but it's still got a blade on it. So a safety razor is out of the question with a hemophiliac, correct? Yes. Okay. I will not allow my child to swim. Why? Why would you not allow a hemophiliac to swim? You want him to swim. You want him to avoid contact sports like football, okay, baseball and the like, but swimming is fine. Okay? I will encourage my child to do range of motion when joint pain occurs. Well, when a hemophiliac has an exacerbation of hemophilia, you have a sequestering of red blood cells in the joints. It is extremely painful. The last thing that kid will want to do is do range of motion. Okay, you rest the joints. Number 4 is the correct answer. I will teach my child safe sex practices. He's got hemophilia, he's 14 years old, and he's got AIDS. And I'm sorry to say, but at 14 years old today in the United States, like little bunny rabbits, they're jumping. Yep. And I'm sorry to say that, but I can only tell you that, I've got, there's a kid who comes into the ER, she's 14, has got 2 kids already. I don't know what to tell you. Okay. Charge nurse on the floor, patients admitted with cholelithiasis and major depression. To whom would you assign this patient? To an RN who just passed boards, a CNA with 40 years of experience, an LPN with 25 years of experience, or any of the above, because it makes no difference. You're a charge nurse, patient is admitted with major depression. To whom would you assign this patient? He's got cholelithiasis and major depression. Would you assign him to the RN, the CNA, the LPN, or any of the above? Which one would you throw out? You throw out 4, you would not, You would assign the person to the RN. Why? Because I know she just passed boards, okay, but she's the only one that really had the psychiatric training. LPN schools you get very, like a lick on a promise, I believe, if that at best, okay?